They produce great surgeons. Let's talk about skin and hand surgeries in voice shots to make it simple.
Take care. Discomfort of the hand is very common with debuting contracture. True pain is not usual. The disease most commonly affects the ring and the little finger. And in case if you don't know the debuting contracture, it's a fixed flexion contracture of the hand where the finger bent toward the palm and can't be fully extended. Debuting contracture is caused by underlying contracture of the palmar aponeurosis. The ring finger and the little finger are the most fingers to be affected, while the middle finger may be affected in advanced cases. Take care, the middle finger may be affected in advanced cases, but the index and the thumb nearly always spared. Again, the middle in advanced may be affected, while the index and the thumb nearly always spared. Debuting contracture management. Surgical fasciotomy. However, the condition may recur and many surgical therapy are associated with risk of neurovascular damage of the digital nerve and arteries. According to MRCS and UK, you can do fasciotomy for debuting contracture. But of course, if you are a plastic surgeon or a hand surgeon, you know that there are some other modalities may be used in earlier cases, like puncturing and steroids. But let's stick to fasciotomy for debuting contracture according to the UK modalities. Bouchard and Heberden nodes are very common with osteoarthritis, and the trick in the exam is asking whether you know where they come or not. The Bouchard, from its name, initial P, it's in the PIP, while the Heberden, it's high, distal. So, PPHD, PPHD. So, let's take some notes about the Bouchard and the Heberden. The Bouchard in the PIP, it's a hard bony outgrowth or gelatinous cyst on the proximal interphalangeal joint, the middle joint of the finger or the toe. They are a sign of osteoarthritis and caused by formation of calcific spurs of the articular cartilage. While Heberden nodes, they typically develop in the middle age beginning, either with a chronic swelling or affecting the joint, or sudden painful onset of redness, numbness, and loss of manual dexterity. This initial inflammation and pain eventually subsides, and the patient is left with a permanent bony growth that often skews the fingertip side away. It typically affects the distal interphalangeal file, the distal interphalangeal joint, the DIP. So, PIP and DIP, Heberden, high distal, Bouchard is proximal. Osler nodes. Osler nodes are painful red raised lesions found in the hand and the feet, and they are associated with a number of immune conditions like infective endocarditis and immune complex deposition. Take care. Giant cell tumor of the tendon sheath is the second most common tumor of the hand after the ganglion cyst. The ganglion is the most common and the giant cell tumor is the most second common. It is slowly growing, usually painless, and this is your key. Painless benign lesion of soft tissue. The tumor affects individuals between 30 to 50 years old and found more often in women than in men. Port-wine stain is a form of capillary malformation that's present at birth and persists throughout their life. It's usually present as macular dark red vascular stain of their face, trunk, and limb. It can either be well localized or could have extensive spread. Take care. Port-wine stain doesn't cross the midline. Again, port-wine stain doesn't cross the midline. Basal cell carcinoma is the most common cutaneous malignancy, and it may be single or multiple, commonly occur in sun-exposed areas. It's nodular or nodulo-ulcerative type. The commonest form of the basal cell carcinoma, either nodular or nodulo-ulcerative. In this type, the tumor is usually single and commences as a small waxy or pearly nodule with clearly defined margin. The pearly appearance is more apparent on light. It may be covered with surface of telangiectasia. Telangiectasia is fine capillary appearance on the skin. As the tumor enlarges, central ulceration occur, result in characteristic rolled out itch, and basal cell carcinoma is frequently painless in early stages. Pain signifies deeper extension with underlying tissue involvement. Bone disease is a very early form of skin cancer. It's easily treatable. The main sign is red scaly patch on the skin. It affects the squamous cells, which are in the outermost layer of the skin, and sometimes referred as squamous cell carcinoma in situ. Keratoacanthoma, molluscum sebaceum. It's a cutaneous lesion commonly seen in the sun-exposed site. Although it's commonly thought to be benign, some authors believe it should be surgically removed because it might be malignant from the start. In fact, it's a well-differentiated squamous cell carcinoma rather than a distinct clinical entity. And hence, it's also known as self-healing because these tumors may be solitary or multiple and are more common in male, present as a fleshy elevation of nodular lesion, characterized by the rapid growth from 6 to 8 weeks, and the short history of rapid increase in size suggests keratoacanthoma rather than a squamous cell carcinoma in some cases, and it undergoes spontaneous resolution within 6 months of onset, leaving behind a very depressed scar. So keratoacanthoma may be malignant from the start or totally benign, characterized by rapid growth from 6 to 8 weeks and self-resolution within 6 months. During your exam in paper 2, you will be manipulated by some awkward situation, like this question, where you have a lady, very old lady, about 7-8-year-old lady, is going to treat a metastatic spread melanoma. And during the investigation, you noted that she has a DVT in her leg. What you should do next? Simply continue surgery and start her own intravenous heparin, because this is a difficult situation. Delaying her surgery will almost certainly lead to widespread metastatic spread of her cancer. A concurrent DVT will increase her mortality risk from the GA. The option should be discussed in detail with the patient. Intravenous heparin makes it easier to reverse the coagulopathy, and careful hemostasis will ensure minimal bleeding. Dermoid cysts are congenital hamartomas, result from anomalous developmental inclusion of the embryonic epidermis along the embryonic cleft closure lines, along the lines of fusion. They are variable size, at times are large as 10 cm. Common sites are the median and lateral end of the eyebrows, the median and lateral epicantthus, where they are called external and internal angular dermoid cysts, the midline of the nose called the nasal dermoid cyst, and the midline of the neck called perineum, and the sacrum. They are usually painless and subcutaneous in location. You have to take care when a child came to you with a swelling in the face, especially in the fusion lines, because it may be in continuity with the meninges and the brain. Necrobiosis lipidoca is commonly associated with diabetes, and it likes to appear in the pretibial lesion. It begins with dusky red plaque and have a yellow cast, atrophic telangiectasia. The center of the lesion is characteristic of this yellow atrophic telangiectasia and typically ulcerate due to necrobiosis lipidoca and slow to heal. It's very painful, frequently complicated by infection. Seborrheic keratosis are benign tumors caused by overgrowth of epidermal keratinocytes. They are seen in large numbers, especially in the trunk, face, arm, and mainly in the middle-aged older individual. They are sharply circumscribed, with develop a single or multiple round oval shaped. Very common in Australia, by the way. Australia very famous of melanoma and seborrheic keratosis. Be modest just like the lesser trochanter of the femur, just to have the psoas major and its major muscle to be inserted in the lesser trochanter. Remember, foramen ovale transmit mandibular nerve, accessory meningeal artery, the accessory meningeal artery, not the middle meningeal artery, and lesser petrosal nerve. The foramen spinosum transmit middle meningeal artery and vein, meningeal branch of the mandibular nerve. To sum up, foramen ovale transmit accessory meningeal artery, while foramen spinosum transmit the middle meningeal artery. You have to be aware of the recurrent motor branch of the median nerve. It supplies the senar muscles, which is important for the opponents. The opponents is what differentiates us from the apes. Yes, it created the civilization. So, be aware of the recurrent motor branch of the median nerve. Either it was a traumatic injury, a patient came to you with a traumatic injury in his palm, or you are performing the carpal tunnel syndrome. That's why in carpal tunnel syndrome release, your incision have to be more ulnar than radial. You have to be at the ulnar side, not to the radial side, to prevent and to protect the recurrent motor branch of the median nerve. And it's called the motor, the $1 million nerve, because it might be missed, and if the muscle atrophied, its repair is hard, and the result outcome is not this much, even it's a motor branch, not mixed. So take care of it. Take care. The long thoracic nerve originates from C5 to C7 root and descend in the axilla posterior to the brachial plexus to innervate the serratus anterior muscle. Then the magic happens. The magic happens when it anchors the scapula to the chest wall. This is the function of the serratus anterior muscle. It anchors the scapula to the chest wall. So if it injured the long thoracic nerve, there is no anchoring to the scapula. That's why it got wing. Hope you got it now. So again, the serratus anterior muscle anchors the scapula to the chest wall. And injury to the long thoracic nerve will cause winging of the scapula and will appear during arm anterior abduction. So the origin of the serratus anterior from the first 8 ribs, and it inserts in the medial portion, in the medial border of the scapula. So when it contracts, it will attract from posterior to anterior, attract the scapula from posterior to anterior and anchoring it. So when it's injured, or the long thoracic nerve of bell is injured, this will cause no anchoring and will cause the winging. Hope it's clear and killed. Sebaceous cysts are most frequently located in the scalp and the hairy areas and have associated with central punctum. You will find a black dot in the center of this swelling. This is a very specific for sebaceous cyst. Sebaceous cyst may have a horn in advanced cases and being ulcerated, which causes a lesion called Cook's peculiar tumor. It's like a tumor, but it's not a tumor. By history, you will know that it is a sebaceous cyst, but in advanced stage. Take care. When you are suspecting a pigmented lesion, you take it excisional biopsy. You take completion of the margin in one of two situations. Either you have intraoperative frozen section and the pathologist tell you it's malignant, so you will do completion of the margin according to the algorithm, or after the operation the pathology report became malignant and you have to complete the margin. But intraoperative, when it's not diagnosed malignant, even a pigmented tumor, you just do excisional biopsy. Acanthosis nigricans. It's a medical sign characterized by brown to black, poorly defined, velvety hyperpigmentation of the skin. It's usually found in the body fold, in the intertrigo, in the hidden areas. Again, it's found in the body fold, such as posterior and lateral fold of the neck, the armpits, and the groin, the navel, the forehead, and many other areas. It's associated with endocrine dysfunction, especially insulin-resistant hyperinsulinemia, as well as the very famous diabetes mellitus. This activates the insulin-like growth factor receptor, which leads to proliferation of keratinocyte, fibroblasts, and other cells in the skin. Activation of other growth factor receptors such as fibroblast, growth factor receptor, epidermal growth factor, which cause poorly defined velvety hyperpigmentation of the skin. By the way, acanthosis nigricans very common to happen as well with the Addison disease. In Addison disease, you will find the patient skin color it changes, and this is a clinical sign. You have to elicit it yourself. When you find someone his facial features doesn't come with his skin color, ask him about an earlier photo for him. You might find that the skin color is not the same as now. He has been pigmented. This may be Addison disease. Bioderma gangrenosum is a rare inflammatory skin disease where painful pustule or nodule become ulcerative and progressively grow. Bioderma gangrenosum is not infectious. Treatment will include corticosteroid and cyclosporin and infliximab or canakinumab because it's highly associated with Crohn's disease. So Bioderma gangrenosum, not infectious and associated with Crohn's disease. And the management will be mostly medical. Take care, sebaceous cysts contain sebum but doesn't contain pus. Sebaceous cysts contain sebum, doesn't contain pus. The pus only present if the sebaceous cyst got infected. That's why we have to surgically excise and remove the whole sebaceous cyst. And the marvelous smart surgeon will extract the whole sebaceous cyst enclosed in its cyst. So there is no recurrence. If you are a plastic or general surgeon, please practice on inoculation of the sebaceous cyst as a whole, and don't interrupt it during the surgery, and don't make it squeezed or cut the wall. Take it as a whole. Be gentle. In surgery, when you hear the word rapid growth, you always think it's a malignancy. But we have some swelling characterized by being benign just for a rapid growth, like the keratoacanthoma. It will be rapid growth, but it will be self-involuted and impressed. Rapid. It reminds us of the phylloids. It's benign. It's not tumor. Cystosarcoma phylloid. It's not a sarcoma. It's not cyst. It's merely benign. But it's a problem. It's big. So when you hear rapid, yes, you think for malignancy, but keep keratoacanthoma in mind in skin lesions and the phylloids in breast lesions. Biogenic granuloma, a friable overgrowth of granulation tissue over site of minor trauma. With continuous irritation, the granulation tissue will lead to biogenic granuloma with a history of trauma. There may be ulcerated and bleed on contact and bleed in touch. They may be treated with curettage and cautery. Formal excision may be useful in some diagnostic doubts. Pilar cysts may contain foul-smelling cheesy material and are surrounded by the outer part of hair follicle because of the histological appearance. They are more correctly termed pilar cysts than sebaceous cysts. I know you are confused between pilar cysts and sebaceous cysts. Dermatofibroma is a superficial benign fibrous histiocytoma. Again, it's superficial benign fibrous histiocytoma. It's a common cutaneous nodule of unknown etiology, occur more often in women. Thank God we are safe men. Dermatofibroma frequently develop on extremities, mostly on the lower legs, and usually asymptomatic, although pruritus and tenderness can be present. Care. Dermatitis herpetiform is commonly associated with the celiac disease. Celiac disease and MRCS. The patient should eat gluten-free diet. It will develop hypocalcemia. It will have splenic atrophy but crypt hypertrophy. Again, splenic atrophy but crypt hypertrophy. Associated with T cell lymphoma and villus atrophy and malabsorption. Contains IgA. So it's T lymphoma, not B lymphoma. T lymphoma, not P lymphoma. Associated with hypercalcemia. Hypercalcemia is not a cause, but it's associated with hypocalcemia. Hypercalcemia is not a cause. Associated with dermatitis herpetiform. Again, associated with dermatitis herpetiform. Again, lymphocytic infiltration, small bowel lymphoma, crypt hypertrophy, and splenic atrophy associated with celiac disease. If you want to do biopsy to diagnose, and the transglutaminase is used for screening as well. We have stressed to inoculate and excise the cyst of the sebaceous cyst without breaking it, but if it's infected and contains pus, so it's incision and drainage and packing without any suturing because it's infected and may be recurrent after this operation because the cyst might be not interrupted. So after this, if the sebaceous cyst came back, you do the inoculation and excision, but it's infected, so we do incision and the drainage. Once abscess, once drainage. Never wait for fluctuation in the parotid abscess, palm abscess, breast abscess, perianal abscess, and perinephric abscess and brain abscess. The bulb space is a closed space infection. It will be highly painful. Severe, there is no space for the pus, so please release. And in practice, when you release the bulbar infection, you will find only simple dot. This makes this pain because there is precipitation in the pulp that closes its space. There is no space for the pus. Bulbar space infection is very serious problem because you know the bulb precipitates into spaces by precipitations. There is no place for the pus to spread, and it will evolve to the space of the corona, and this advanced stage will cause osteomyelitis and severe hand infection. Please, there is no space in the pulp to leave it. There is no wait for fluctuation in pulp space infection. Even it will be giving you a simple dot after incision. This will make a huge difference in the patient life expectancy. In the perianal abscess, it will cause a fistula. And believe me, no one needs a fistula, especially in this area. And most of the high anal fistulas, which are very challenging cases, is due to, yes, perianal abscess which was neglected. Someone asked me why brain abscess should not be waited for fluctuation. Simply, brain sometimes important. Remember, renal metastases have a tendency to be hypervascular. This is considerable importance of surgical fixation is planned in bone mets of renal mets. Take care. The primary cancer that causes bone mets like breast, bronchus, renal, thyroid, and prostate. But when we ask about the most common cause for pathological fracture, it's indirect question for the most common tumor of them all, so it will be the breast. Any subcutaneous collection is almost always advised to do warm compression. But take care, the application of cold compresses is indicated in doxycycline because Extravasation of warm compress increase the risk of doxoprosine ulceration. That's why cold compresses is indicated in doxoprosine. The hyaluronidase is indicated in the extravasation of contrast material and TBN and benzyl alkaloids. However, if administered following the doxoprosine, extravasation will be dramatically worsen the situation and it's contraindicated. In case you forget, the chef will always serve us with Pepsi after meals. The chef cells in the stomach will serve us with pepsin and gastric lipase. Just remember, ascorbic acid vitamin C is very lovely for the plastic surgeon. When you want the wound to be healing good, we give vitamin C for the patient because it's responsible for the quality information for the wound healing. What to use for GFR, inulin or creatinine? Creatinine is most commonly widely used, but take care. If the patient has renal failure, we have to know what is the difference between the inulin and the creatinine. Inulin is the perfect glomerular marker. It's not bound to the plasma protein and uncharged, freely filtered across the glomerular capillary wall and completely inert in the renal tubule. So, it is a perfect glomerular marker. Creatinine, it's not perfect, but it's good. It can be freely filtered across the glomerular capillaries, secreted to a small extent. The clearance of creatinine slightly overestimates the GFR. So, creatinine is more convenient because it's endogenous and you don't have to infuse it like you do for inulin. And the plasma level for creatinine is related to the age, gender, muscle mass of the patient. So, creatinine declines with the age due to decline in renal function and muscle mass. Glucose, protein, amino acid, and PAH are reabsorbed by the kidney. So, the most accurate measure for glomerular filtrate rate is inulin, but in practice, we use creatinine, except in some few situations, inulin, because the inulin is a perfect glomerular filtrate rate marker because it's not bound to any plasma protein and uncharged and freely filtered across the glomerular filtrate wall. Again, completely inert in the renal tubule.